Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
And so it's my great pleasure to have Dr. Tro, also known as Dr. Tro Kalayjian. and so I'm going to have to correct me with the language. And you're living in Japan.
Yeah. So I actually live in a small little town in just north of New York City. It's called Palisades, but my office is in Japan. Yeah.
Okay. Well, I looked up the pronunciation of it. It looks like Tapan,
Yeah. Actually, it's a Native American name. So it's a Pansy, which was the name of the bridge. It's a Pansy Bridge or Tapansi.
Right. Okay. Right. So why don't we go way back? So I did a little homework. I went to your site and the company, learned a little back. You guys have these great bio videos, which is awesome. All the staff has their story there, and I could not believe your story, Tro. I mean, that's not you on that video from the past. I just, so let us. I don't know if my membership folks know who you are, but assume we know nothing. And it just couldn't have been you on that. You have changed, your physical look has changed so much. And so how about start from, I was born and raised.
Yeah, I mean, like, Eric, how far back do you want to go? I came from a family where everybody was obese. My mom ended up having bariatric surgery, as type 2 diabetes, struggled with weight her whole life. My father also struggled with weight. My older brother and my younger brother both, have oscillated anywhere from 300 to 500 pounds. And I was following sort of in that footsteps. And
did you grow up there in that area of New York?
Yeah, I grew up outside of New York City. Parents, they were first generation Armenian immigrants, and they came to this country, lived the American dream, worked 2 jobs. They're both accountants now, they're successful, but, they went to college at night when we were kids. And growing up, we had a mix of, ethnic cuisine, and we also had, pita bread, rice, etc., the sort of Middle Eastern cuisine. And then, we grew up with, cereal and Pop-Tarts and, whole grain toast. And, so we grew up in the modern, and then we went to school and got fed school lunch. So I was a product of this, standard American diet, and, the product of, immigrant parents who were working and trying to, maintain some of their ethnic cuisine. But really, when you're busy working that much, you just can't, you can't keep that up, right? So I was a product of the standard American diet. I was a product of processed food companies. And at the age of 13, I was 200 pounds, which is what I weigh now. And I remember going to my family medicine doctor at the time for my annual physical. It was my birthday. And he looks at me, and I was 205 pounds. And he says, you're 5 feet tall, you're 205 pounds. You're going to be just like your family. Like, if you don't change things, And I remember sitting in that office for 2 hours to wait to see him on a hot, July morning. And I remember thinking to myself, this fucking jerk just told me, after making me sit 2 hours with a TV and a chair to go lose some weight, like, where's the freaking exercise bike, bro? Like, you're going to tell me to lose weight? I remember thinking this at 13. And that was my primordial ooze, I was always like question authority, and, I had that stint in me. I had this chip on my shoulder.
So,
and
I
was a chunky kid,
Did you always want to be a doctor?
That was the moment. I remember I was like, I'm going to do better than this guy. I'm going to beat the genes. He said, it's probably in your genes. And it's like, I'm going to beat the gene, and I'm going to become a doctor. I'm going to show him,
That's funny. I learned from some people what to do, right? Some mentors, and I learned from some people what not to do. you know, so that
I mean, he was a good doc. He was always there for our family, Dr. Adis. I remember him. There was, I don't think he was a bad doc, but he just didn't know how to deal with whatever it is he was looking at. He didn't know how to deal with, the processed food environment, the modern, obesogenic environment, we call it. He didn't know how to deal with it other than to elicit shame and try to inspire me to change.
And not much has changed in the traditional doctor's office today, I'm afraid, right?
Not at all. And that was my primordial ooze. I remember that was like, I'm going to become a doctor. I was 13 years old was the first time I thought of becoming a doctor. 13-year-old, I was like, this clinic could do better. I mean, that's where I came from. And, I tried to fight it. I didn't eat for a month after that. I've shared this before. I didn't eat for 1 month after that visit with that doctor. So just to give you an idea of sort of, I was a troubled kid to some degree.
Well, we don't need to know all of it.
No, I mean, like, look, I'm comfortable with it now. And then what happened? I gained all that weight back, 10 pounds per year, despite loving to exercise, despite running, despite being vegan, despite counting calories. I put on 10 pounds per year every year through medical school, through residency, all the way into being attending. I was 350 pounds. And I think that's the pictures you were talking about that I saw.
So for those watching, if you want to, it's a 3-minute bio, including these old pictures, which really are, it doesn't look like you, but it was. And go to the drtro.com under the staff headings, and you'll get 3-minute videos of everyone's story, which I went through a moment ago. It's just, what a great team. But so when, how did you find the low carb or answers? You clearly were searching and probably following what everyone was telling you to do, which we now know doesn't work for most people.
Yeah. So, I had a chip on my shoulder, right? I mean, me, we've worked together on some projects now. I think you have a sense of my character. And most people who follow me on social media or listen to the podcast know I have a bit of chip on my shoulder. So
that has a negative connotation. I don't think that's what it is. It's, you get on something, you hold on to it till you figure it out, right?
Yeah. Well, so that's how I was with medicine. I mean, with medicine, I remember, I was studying medicine avidly. I was the chief resident. I was in the Yale internal medicine program,
Yale?
Yeah, it's a Yale affiliated. So
you mean the Duke of the North?
The Duke of the North, exactly. Yeah, it was a great internal medicine program. I mean, I had all the esteemed lecturers from Yale, basically lecturing me every day, and I soaked it all in. I mean, I've been a lifelong learner, interested, curious, and eventually I was chief resident there, and. I loved medicine, and I scored on the 90th percentile in my board exam. I mean, I love to learn and I love to read. And so, but here I am, 350 pounds, like totally blind to my own obesity and what drives it. But yet so knowledgeable in the way that we train residents. I was training residents. I was training other doctors and medical students, and yet it was such a blind spot. And I don't think it, and what I realized was not only was it a personal blind spot, but it's professionally was a huge blind spot. And that took me years to understand. I wasn't always this firebrand that like wanted to just topple it all down. When I was 350 pounds and my wife really challenged me to learn, what is obesity? What did I do? I read your textbook. I read all of your papers. I read I read 3 textbooks on obesity. I went and eventually got certified, 3,000 papers, all the studies that you and others have done. And I'm the type that I'm going to go read what the other people say. I'm going to read their citations like we did, with the pediatric paper that we're working on now, the pediatric consensus statement on low carb that we're sort of critiquing, but that was my thing. It's like, I'm going to learn medicine better so that I can train med students and residents better, inspire them to learn, show them that their knowledge will save lives and their ignorance will kill people. And so when it came to obesity, I was like a sponge, like just soaking it all in. And when you look at the evidence, I mean, you know this, all the, like, what would I do if it was pneumonia? I would look at the antibiotics or first determine the etiology of pneumonia. Is it bacterial or viral? And then I'd look to see, if it's bacterial, which is maybe the most common, maybe not now in the COVID era, but prior to that, bacterial was the most common. You'd look at the antibiotics. What's the efficacy of the antibiotics in head-to-head studies? Which ones, what are the side effects? Like, that's how I approached obesity. I was like, show me the head-to-head studies. And I'm looking, and it's like, low carbs better, low carbs better, low carbs better. I'm like, look at the Shea study, look at the...
So about what year was this?
This was, so about 8 or 9 years ago.
Okay.
So
that first round of low carb versus low fat, 1,000 studies were out, and low carb wins, right?
Yeah, the New England Journal. Yeah, exactly. A to Z trial. I mean, this is all back then. And I'm like, what? Like, and then so of course, being curious, Eric, I would have, I did what you did. Like, are these guys real that are promoting it? I'm looking you up. I'm like, Gary Tao. I'm reading, are these guys real? And then I'm like, well, I better look at the people critiquing those people. Let me go read How Not to Diet, see what Gregor's saying, see what, McDougall's saying. And I'm just reading, and like, it's anthropology to me. I'm trying to figure out my own struggle and figure out this field, and then you start to like unpack layer after layer. Well, how did we get here? How did we get to recommending whole grains and multiple meals? And how did we get to including, 5 fruits of fruit, 5 servings of fruit when actually 1 or 2 is all you need really for the mortality benefit. After that, it's not a benefit. So you start to look at the data and understand, holy crap, how we got here is a house of cards. And the strongest data we have is supportive of low carb. And that was it. I was like, I just want the best antibiotic for my problem. And so I started with low carb. Like, I'm just looking for the most likely to succeed solution to my issue. And then, you peel layer after layer, like, okay, what are the drives to eat? People eat because they're hungry. People eat because they have, a sleep deprivation. People eat because they're anxious. People eat because they have emotional eating. People eat because they maybe have food addiction symptoms. So, and all of these are true for me, all of these, right? I was hungry. I was, addicted to food. I eat out of anxiety. I eat emotionally. We all do. It's human nature. But so you learn about all of these things, and like, then the story becomes so crystal clear. Blood sugar fluctuations modulate most of our appetite. Sleep deprivation makes us eat as if we're hungry, right? Anxiety makes us eat as if we're hungry. And then it becomes clear, right? It's, obesogenic foods, carb fat combinations make you eat more. Carb fluctuations make you eat more. And then, you peel away the science and it's clear. Now you know why. Now I know why I had a lifetime of struggle. It's very clear.
What do you remember the first day you started?
Yeah, because I remember it was like right after my wife, we had a miscarriage in between kid 2 and 3. And, we were talking and we were having a tender moment. And, she said, are you going to be alive? And I remember, November. It was like, it was mid 2015 or, November 2014 to November 2015 when I was really avidly reading. And then I like fully committed. I haven't had bread since 2015. Let's put it that way. I don't remember the last orange I ate. Let's just, put it that way.
You're still alive.
Yeah.
Well, so, it's interesting. Most people who quit smoking remember the day they quit smoking. It's like a milestone etched in their mind. And this is kind of like a quit smoking. It's a quit carb day that, it's an impactful moment. I suppose you didn't, just have immediate success and, there were no bumps in the road.
I mean, I'm going to tell you, I recently lost, there has been a lot of bumps. I mean, I lost 80 pounds in 2015. 2016, I lost like 60 pounds. I lost another 10 or 15 in the ensuing year. So I went from 350 to like 195 or so, and, but I always had a love for exercise. So that, that's always been a constant, martial arts, running, weightlifting, always did it, always liked it. So that didn't really change much. But, when my body felt good, maybe I was a little more committed to it than historically, maybe going from 2 or 3 days a week to maybe 4 to 5 days a week. So I lost weight, kept it off, and then started like a punk. I remember it was 2016 where I cold called Mark Cucuzella. So it was 2016, 2017. I called him up, and I felt like maybe like you with Atkins, it was sort of the same thing, because I saw the change of my life, and I was like, I need to make systemic change. And he was doing systemic change at West Virginia. I cold called him. I'm like, I just found his number on Doximity or something like that. And I call him up, and I'm like, you don't know me, but I know you, and I've seen you talk. And I said, tell me how you did it, right? Tell me how you did it, and tell me how we're going to get, 100,000 doctors to do what you're doing, right? Which is make West Virginia, drop sugar. Unfortunately, they reversed that since then.
Yeah.
And
well, that I didn't know that part of the story, but I think that's important to reach out and actually find that these doctors are real. It was important to me that there was a doctor in practice, and the only one at the time was Dr. Atkins in New York City. So I visited him. That's 1998. But you didn't? Did you actually go visit Dr. Cucuzella, or you were just convinced by phone, or learned what to do?
I mean, I was convinced because it worked for me, and then it worked for my family, and then it worked for, people. So I was convinced because I was like, wait a second, I'm not hungry anymore. Like, why am I not hungry? Right. And so I didn't need any more. The data supported it, the interventional data,
right.
It worked in me. I don't need it anymore, But what clicked in me was, holy shit, the amount of suffering we have. And when I saw, like, I tried to, like, I was like, is the ACLM? Like, I went to the, I went to ACP to see, is there anybody thinking about nutrition there? Nobody's there thinking about nutrition. I went to, eventually I went to the ABOM, but even there, they don't really care about nutrition. They care about drugs and Coca-Cola,
Well, and then the lifestyle medicine is the
vegan front.
Yeah.
The Adventist front. So I was looking for like a tribe, really, because I'm like, okay, this has affected me, and I'm just like trying to find a tribe. And, eventually I find Doug Reynolds, and, I reached out to Mark Cucuzella. I'm like, how did you do it? Tell me what you did. I'm going to do it at Yale. And then he was like, you're never going to do this. It took years. And, there's contracts. He didn't say it like that. He just said it's going to be challenging. And so then I wanted to be the doctor I wish I had and learn everything, right? And then I wanted to make a clinic I wish I had. And that was the time, 2017, 2018. I was like, I got to change, my career. I got to get out of, being in hospital medicine, and I got to go do this because nobody's doing it. Like, nobody is, I shouldn't say nobody. Certainly you were doing it, and, but like, and I
don't know. That's a fair statement. And
there was like no organization, we don't have we never had this organized group of doctors. And I just was like, I wish I had a network to pull from. And at the time I was like, I reached out to Jason Fung. I was just grasping at straws, like somebody help me get this clinic and do this thing,
So it's great that you didn't have to recapitulate. You didn't have to do the clinical trials, which I felt I had to do, 15 years earlier. So, we didn't have any data that was published. So that's fantastic that you didn't have to do those studies. You read them, you were convinced. And then
I read your textbook. That's what I did.
And I love it. But now, so what I tried to do some years ago, and it was failed, was to do a company within doctors' offices. And so we had the method, we had the handouts, we had the clinic idea, and we went, and no doors opened. It was like there were a couple doctors that wanted to do it, but then they'd go talk to their management, and then the doors were shut. And so we tried to scale things up. It didn't work within the system, at least 10 years ago. And now, but you decided apparently to open your own shop, right? To do your own clinic, which is brilliant in a sense, because if you had tried to do it just within the medical system as it even exists now, you're going to get a lot of doors shut in your face, I think. So tell me how the clinic came about.
Yeah, so I wanted to create a network. So I remember in 2018 or 2019, I went to Doug Reynolds. I'm like, we need to make a medical organization, right? I was like, we need to make the medical organization I wish I had. And I've been able to be a part of that. You're a part of that. We're all working together on that. And that's been so fantastic, the SMHP. And I, at the same time, maybe a little bit earlier, I started doing telemedicine consults, this was 2017, 18. And then I said, okay, I'm going to focus on telemedicine consults. And the premise was like, look, people don't want to come to the office. People don't want to come in. Like, we need to do everything remotely. And this was before COVID. We had remote scales, remote blood pressure cuffs, CGMs, I'm a technology guy. I play around with ultrasounds and, so I was quick to embrace technology. And because I was like, I want to make this easy for the person. They don't need to get dolled up and come in. They don't want to sit on my, waiting room chair. They don't want to sit in my, office. Like, let's just make, weight loss very easy. And, then that became an app, and, that we have health coaches now, and you talked about our team. We have an amazing.
Okay. So there never was a brick and mortar place.
We have a brick and mortar place. It's in Japan, but it's we have, it's mainly remote. Like less than 10% of our, like we deal with employers now in multiple states. Good. But it's just completely remote medicine. Nobody's coming to see me.
But then you decided to not be in the insurance system, right?
Yeah. So, well, the problem is so like all these things that I just mentioned, they're not really reimbursable. And, but like yet
talking about food, no code for this.
Well, not just that. These things like setting up meetings, like the way you're doing right now, like getting people in social groups, getting people in small groups, creating a sense of community, delivering asynchronous education, videos that people can watch. None of this is a billable event. So it really needed to be outside of insurance. But interestingly, I didn't know if I was going to even make it. I was like, who's going to do this? Who's going to want it? And, now we have companies saying, like, we have corporations saying, help our, we're building off the data that you mentioned. Like, we're able to save companies money while, like, our companies are giving our service for free to their employees. We're reversing diabetes, which is our mission. The people are getting healthy. The average weight loss in our employee cohort at 1 year was 40 pounds. Yeah. Like, I'm going to, 40 pounds. And so, now we found a win-win-win scenario that works. But, also we get the people that, I'm sure I know you get it all the time. They come to see you and they want to, they're looking for expertise and, we do get like the direct to consumer, but the idea here is how can we, I've been laser focused on the practice I wish I had. Going back to 13 with Dr. Adis, like, I want the practice I wish I had. I want to be able to text and get some answers. I want to get, I don't want to come in to do something if I can just do it. If we're going to titrate medications, why we can do it in real time,
Yeah. I was kind of skeptical, and it's funny when people come in, or you may be watching this for the first time, or if you're new to the low carb keto world, some people perceive that I'm kind of a radical early adopter, and I'm not. It took me 8 years of clinical research to validate and become comfortable with something that was so, it was so radical in 1998 to feed people fat that the hospital director was lobbied to clamp down on our first study and to squelch it. So everyone knew eating fat would be bad for you. And it turns out that's not true. But we've come such a long way, and the food being the most important thing, it's really not been appreciated internally inside the system. And so I guess I just want to say that one thing you told me that really resonated is that you're limited by insurance in what you can do. And so I chose to be within the insurance system just so I could figure out how to do it and to see a wide range of clients in Durham, because most people have that kind of insurance. It's not a big kind of area, but the ability to go beyond what insurance would be paying for, doing it on your own, is actually it's brilliant. And it's time is now, I think, such that there are enough people and enough background, there are guidelines to support this. I've noticed that your staff is growing.
Yeah, I mean, well, let's take a step back, because I should be much more appreciative. I think, so I should really be thanking you.
Well,
I have thanked you. I've thanked you many times. So well, thank you again.
You thanked me.
Yeah.
On Low Carb MD podcast, I looked it up. So Dr. Kalayjian
3 times.
Yeah, I was on episode 130, 155, and then you interviewed Scott Parker on 226. Thank you for that.
Yeah.
So I should have led off by introducing you as the leader of Low Carb MD podcast.
Yeah, with Dr. Brian Lenskis is a
Yes, Ryan
guy.
Yeah. Hey, I told you you hadn't interviewed me, and you said yes, I haven't. Okay, there you go.
So it's I'm going back, and I'm wondering. It's like I still it's funny. You talk about fighting against the grain, having to do these trials, having to fight and I'm here trying to build off of that, both professionally, as an entrepreneur, I guess, but also also manifesting what I wish I had more, and creating the SMHP has been such a value to me, to be able to have an outlet that's it's great to hustle, and for your own business and stuff like that, but it's also very rewarding to make the world one step closer to something you wish you had. And
absolutely. Well, I mean, I'm so inspired by you and your story that I think it's going to grow. And if someone's watching and they need help, I get requests all the time. Can I get a keto-friendly doctor near where I live? And we have these loose website places that will kind of direct you, but how many states are you in now? As
every state. So we have a big team. You mentioned we're growing. We have Dr. Laura Buchanan, who started with us about a year ago, and she's still taking patients. I very rarely see patients. I see them with either in conjunction with Dr. Laura or with we also have a PA, Mary. Mary. She's awesome. She was my first medical assistant, always inspired. She went off to PA school. She actually came and rotated with me as a PA. We wrote a paper together on a interesting Cushing's case, and now she's come back, and she's been inspired by sort of metabolic health, and she'll be at the SMHP conference in January if you guys want to meet her, but on type 1. So
to just spell out, so the Society of Metabolic Health Practitioners, SMHP, is really an outgrowth of, Doug Reynolds, Pam Devine, but then also your tour de force, Tro, and
yours and Rob, and
we're on the board together, and they're great leaders that are trying to find a home for people that you don't have to be a physician, right? So I really love it because you can be a coach, you can be a dietitian, you could be a PA, and you can be a member of this organization that allows for the fact that you can change metabolism by changing the food. It's not just a low carb keto organization, but it embraces that. And anyway, that's kind of a sidebar of bringing other people into the fold, and also raising the credibility of what we're doing. This summer, the ketogenic textbook came out. It's the first real textbook on clinical use of keto diets for among other things, diabetes and obesity and metabolic disease reversal. But the science in there, pointing toward brain health and autism, and anyway, that again raises the credibility of all this. And so I wonder now, in real time, what's the response? Are you getting any negative responses from things? And I have to. I'm predicting that you're not. You're going to get the things will just kind of people will let you, like the water has parted and you're going to be walking through.
Well, I'm going to be honest. So it's every day has been a struggle. I have, in 2018, I left a full-time job in the health system, and I have not taken that salary yet. Right, I am still at 1/3 of that salary, so I've invested everything into just making the home I wish I had. This vision, and that I think you share, and I share, and a lot of other docs share, and I think you've really come, adapt. Creating the community. You've done all the elements to it. You've done it, and I think So, we have 4 awesome health coaches, 2 personal trainers. We have a team of 12 now and growing. My wife's also helping. You'd be surprised when you deal with employers, the contracts that come.
Yeah. Well, so if you're watching this and you don't know much about low carb or keto, this has come so far that to summarize, you've been able to use your own personal experience and then the data that had been collected over the prior 15 years to kind of just assume that it works and it's safe and start practicing. And yet the need is so great that it's got to just keep growing. I mean, so one area where it just makes such sense is a self-insured company. A self-insured company is paying for any extra health care that their employees have. So like you were saying, they provide this as a service, don't even make the employee pay for it because they know they're going to be paying less in the long run because they've fixed their diabetes. I mean, one person goes on dialysis and it's $20,000, $30,000 a year out of pocket for the company. So, Virta Health, I think, right, kind of push the envelope, but it's such a labor-intensive thing, and they have their own preconceived ideas of what the diet should be. And how would you compare what you do to the Virta program?
Yeah, so we have we're a lot more invested in maybe dealing with the entire package. So we are like a concierge metabolic team. You have a health coach, you have a personal trainer, you have live meetings, multiple live meetings. We have multiple, community meetings just like this so people can attend. So it's a little bit more immersive than Virta. I think the nutrition is very similar. We probably go a lot more into cognitive behavioral therapy and motivational interviewing techniques that they don't do. We tackle food addiction head on and binge eating head on. We deal with comorbidities like sleep apnea, we deal with everything that an internal medicine practice would deal with that relates to it. We're very lab intensive also. Probably in a 6-month time, you'll get 3 labs done very systematically.
Do you require using an app for food entry and measurement of ketones and things?
We are CGM and ketone meter. We support the use. We use remote monitoring. So every patient gets remote monitored body composition scale, a blood pressure cuff, a ketone meter, or CGM. Sometimes at different times. So maybe initially CGM, later on ketone meter. And all of it is connected. So the patient just uses it and it sends us the data. We have an app that's, so just to get an idea, the average person is meeting somebody from our team at least weekly from the day they sign up, to about 2 to 3 months, they're meeting with somebody from our team weekly. And whether it's a health coach, getting onboarded, seeing a doctor, and they have access to multiple meetings throughout the week that they can attend. They have asynchronous courses they can use up. The average person in our program has about 500 to 600 touch points in the 6-month period, meaning they're interacting with our medical program in 600 ways, whether they're going on the app, whether they're finishing a course, meeting a health coach, texting a health coach, going to get, going on the scale, using the CGM, whatever it is. So it's a very immersive, it's very different. It's a lot, Verda is a little more hands-off in their approach, and we get a lot of they do great work, amazing work. And I think, they can't be a concierge metabolic service. They can't be, I don't think you can systemically manage food addiction, right? So and these are areas that I think we focus in on. And then, we deal with all the comorbidities that we see in your clinic, the sleep app, we do sleep studies, remote home sleep studies, we do remote ambulatory blood pressure monitors, we do remote Holter monitors. I mean, if somebody hasn't, palpitations, or if we suspect sleep apnea, we get that sleep study. We also do genetic testing, if the cholesterol seems abnormal in that sort of genetic range, or if we, suspect that there's a low insulin production due to, certain types of diabetes. I mean, so I think it's just, we do cool medicine. I mean, I don't know what to say.
That's great. Well, it's much more intensive than my approach. I learned from Dr. Atkins, who had a list of foods. It's on one sheet of paper, and then had check-ins, about every week for that, but with nurses or other staff after a full H&P with lab tests and all. And I've kind of gotten less and less strict as time goes on, but I lose success with those who need that high touch sort of contact that you have with your approach. I think that's fantastic.
Yeah, I mean, look, honestly, if they don't, like, the people coming to me, like, if like page 4 works, page 4 is like what I give to everybody. Well, and it's like, okay, well, how do you help the people, who just who need more? And I think that's, David Unwin actually said it really well. He posed the question actually really well. Another mentor of mine is just such a beast. I think an absolute, force in the field, just like you. And he said, when really smart people do silly things, we have to think about food addiction.
Yes.
When really, really smart, successful people start doing silly things, and look, I'm a self-proclaimed food addict.
Well, so I would like to switch gears, and then for the live folks, have some questions. I've built in some time for Q&A. But so give me your latest thinking and how you talk to patients about cholesterol.
Yeah,
I get questions all the time.
Trying to toe the line. Yeah. So I'm going to talk. I'm going to make it more medical, and then we maybe translate it down. I'm a big believer in risk stratification. You try to determine how high risk somebody is. Maybe you use a CAC. Maybe you look for evidence of soft plaque. Maybe and if you don't have any of those things, frankly, I don't really care unless I think there's some genetic issue which we can test for now. So and I'm going to tell you, less than 2% have some genetic underpinning, right? So meaning 90% of the time, I don't care. I don't want to say I don't care. I don't care if somebody's health is improving, their diabetes is resolving, their metabolic syndrome's resolving, their blood pressure is resolving, their weight's going down, if they're now more active, if everything is improving and all we got is a bit of cholesterol, usually that's the trade-off I'm willing to accept. And most people, their risk drops. So coming back to what you said, which is, what do we need to do? Like, I've tried to build off of everything that you've done. And when we work with these employers, we track everything. And we tracked, in the first 12 or 15 employees that we were working with. And now it's, in that company, it's 100. And we have another company that we're working with, another one coming on board. We have 100 employees, and the average cardiovascular risk reduction was 44%. Like, we just plugged in the numbers, plugged in that they remitted diabetes when they did, plugged in their blood pressure, and we calculated their AHA, ACC cardiovascular risk, meaning like we did what the guidelines say to do. Okay. Yeah. The cardiovascular guidelines, and their risk dropped from on average 9% to 5%, right? And 5% is considered low risk. So we made them low risk on average, with LDL being neutral, maybe slightly high, slightly like a point or two higher, meaning we're making people healthy.
Yeah. And it's just a different tactic or a different tool.
Yeah.
It's a different intervention.
I think I'm probably more trigger happy than probably you, than what I guess you'd be, meaning like everybody can get a CAC, everybody can get a carotid ultrasound, everybody can get a femoral artery ultrasound, and we can just look for plaque, very easy. And if we have it, then we think just slightly differently. We think so more deeply.
So is there a role for cholesterol lowering or statins, other medicines like that, if you do have disease? What are your thoughts there?
Again, it's a risk. So like I'm a numbers guy, right? Like, just so I believe in, just tell me exactly what the benefit is and what are the harms, right? So I literally calculate it in front of patients. Like, let's just extrapolate this from what we know. Marianne DeMasi did a great study that was published in JAMA Internal Medicine last year on the relative risk reduction of statins of around 20 to 30%, let's say. Okay, so if your risk is 2%, over 10 years, right, we're talking about like a 0.5% reduction or less, right? And that's a lower benefit than the incidence of diabetes that we're going to cause, right, with statins. So I think, most people, you just present them the data, like, here is the risk benefit, here is, what do you want to do? And, most people say, I don't want to do it. Some people, you run their risk and their risk is like 20% and or they had an MI and, then maybe then you're using a statin, and there's non-statin drugs now. I mean, there's bempedoic acid. There's so many ways to address the problem. I mean, there's colchicine for coronary artery disease. There's a lot of approaches to the same issues. So but I think in terms of, the problem in modern lipidology, and I know you know this, is, the whole population's been insulin resistant. And so that's what makes LDL atherogenic. It's not the LDL, it's the insulin resistance, right? So, but lipidology doesn't view it like that. They just pretend like it's the LDL without the insulin resistance. No,
it just happens.
Yeah. I think because they can't see that their data sets are contaminated, right? Their data sets are not pure data sets. These are insulin resistant data sets they're dealing with, right? And that's tough for them, right? They see one way, they see LDL bad. And
well, so I have to bring up the case series that you published, and I want everyone to know that you're taking your cases and putting them into the public domain for review and all. But so in one of the series for the super high LDL responders, you found that by adding back some carbs, the LDL came back down. And what did you end up doing with those people? Are you still worried? Did you?
Yeah, I mean, so the prototypic case, this is interesting, right? So I, just so every listener knows, I was called an embarrassment by several prominent lipidologists for publishing this, because we literally showed that you can modulate LDL more potently than the most expensive drugs. We showed that, and like people call me dogmatic, but I'm like, I literally gave people a sweet potato. I'm like giving people carbs, like, and we gave them this. So just if if you get very lean and you remain on a low carb diet and you're time restricted, you're going to see the LDL rise almost like clockwork. And, Dave Feldman's theory, I think, of that lipid energy model, it's, it exists in the anorexia data. And I think he's just really coined it well and made it very palatable. And he continues to do research on it. I mean, it's just true. And, I said, these people all did not, they're like, I will not take a statin. And they signed the paper saying, I'm not going to, I was like, look, the guidelines say take a statin. They're like, I don't want it. I'm like, I'm not dogmatic. I'm not paternalistic.
But so did you end up with the people who you could lower the LDL by giving the sweet potato and other carbs? What did they end up doing? What did you end up recommending?
Yeah. So we gave them a sweet potato, right? And these guys were all exercisers and, or massive weight reduced people and, or somebody who had, they're doing keto for a neurologic issue, right? So you have to be careful, right? Because, if somebody is bipolar and, they're doing keto for mental health benefits, or somebody has, seizures or neurologic issue. And so you have to be super careful, and you want to, I got to be honest, I don't know. We don't know what happens with it. Like one of those patients had a 797 LDL. I don't think, have you ever seen a 797 LDL, Eric?
No, only in your paper.
Yeah.
I was looking through 450 is about
the highest. Yeah.
Highest.
797. And so we gave him back carbs and, I think he subconsciously reduced saturated fat slightly, but not to any degree. I mean, he still eats beef, he still eats eggs, and his LDL got to 180. So with no medication.
Yeah.
So we have.
But I'm trying to. Are you worried about the LDL of 750?
Am I worried? I think. Look, I admit that I don't know.
You're a practical guy.
So,
I know. We're all taught that would just be outrageously bad.
Yeah, I mean, I can't. So I think, if you look at Mr. Fid and you look at the observational studies and you look at the genetic studies, it looks like a linear. Like if you can approach the mean, why not? Right? If you can, and there's no. That was the thinking of lowering their LDL. It's like, okay, do you want to be the top? I mean, that patient is probably like one of the highest LDLs in the documented literature, right? Like maybe like the top 5.
But maybe it's a good thing.
I don't know. And I told him that, and I was like, I don't know, but you are at the 0.01%. And do you want to be? And so we came to the he didn't want to be. And that's why he came to me. But he didn't want drugs.
Well, I just wanted your opinion and because I don't know the answer.
I think my heart of hearts, I think that, it's sort of like blood sugar. Do you want it to be high? Probably not. Do you want it to be low? Probably not. Do you want it
so Goldilocks, just right.
Yeah.
Not ethical.
yeah, I mean, like the truth, it's same with like temperature. What do you want your temperature to be? I mean, I don't want it to be 107. I don't want it to be 97. I want it to be like somewhere. I don't know the answer, but I know enough to say this is really deviated. And if we can approach the mean with a sweet potato, why not?
What's the harm? Yeah, well,
Right.
thank you for that. And of course, we're all anxiously awaiting the study that.
What do you think? You tell me. Like, I'm curious.
No. I'm here to get your ideas, because I don't know. So my kind of response would be, well, let's follow it. Now, Will Yancey, my colleague at Duke, who's 10 years younger than me, is more cautious. He's one. Well, he would say have fewer saturated fats and maybe have back. And I'm not sure. I mean, I am anxiously awaiting, like we all are, the study that Dave Feldman got GoFundMe money to do with the CT angiogram center, on Earth, one of the best places. And they have 100 people enrolled with all the coronary angiograms. So it's not the calcium score. It's actually looking inside the arteries. And 100 people who said they were doing keto have all signed up. The scans are in. They have a paper that apparently is under review. I just saw it. Dr. Budoff is going to give us some results at a meeting in December. So maybe that might be the first peak we have it. And but the study itself is not just that first data. It's following people then for a year, documenting what they're eating and that they're in ketosis, and then they're repeating the scan again with these really high LDL levels, and it will be very interesting to see, if it's all, no progression, that's going to be the best result. If they all get worse, well, we'll have a good result to know the answer. I'm afraid it's going to be messy, where, some people will have progression, others won't. But the idea that it's being studied is really important.
I'm excited.
Dave went around. Dave Feldman, went around as a computer programmer without the reputation and the credential to try to get the mainstream people interested. And they said, you're crazy, kind of like people have said about your patients whose LDLs went up and then you brought them down. No, it's not crazy to collect new data. And the metabolism is so different. It's like comparing what goes on the moon with what goes on Earth. The metabolism is so different. So it wouldn't surprise me if the LDL of 750 is actually healthier. It wouldn't surprise me.
Yeah, the buy is smart. I don't know. I mean, I think this is. If there's one thing I've learned is a good doctor should say. A good doctor is somebody who says, "I don't know" often.
Well, and I guess I'm a great doctor.
So I just have to say I don't know, and there's mixed data. Like there's a bit of mixed data, right? So, you look at all-cause mortality, and it's a U-shaped curve for LDL, and the mean is around 140, and the standard deviation's around 20 to 30, and so do you want to be 5, 10 standard deviations away from the mean?
But that's among carb eaters.
I know.
Right?
I know. Well, so and then, but so I don't know. I don't know.
But you're right. So the one way sense the sodium level for carb eaters and non-carb eaters, we would assume is pretty close, right? Or the potassium level. But another project that Dave Feldman is embarking on is the company called ownyourlabs.com, where you can opt into having your data used, like to get a normal range of hemoglobin A1Cs for carnivores, for example. That'll be interesting because some people don't get the total reduction in A1C that you would expect based on their blood glucose, and some people have a little elevated glucose. So I guess we talked about a lot of things. I wanted to mention Rosette's mix, because I met your wife, who's cute as a button, giving me cookies at these meetings, which are delicious, tell me a little bit about Rosette's Mix.
Yeah. So, my wife, is an amazing person. She really inspired me. She's an attorney, and she, along my journey, sort of being the support system, and herself having migraines and going low carb and, not having migraines anymore, really.
Wow.
She used to have migraines like three, 4 times a month, and, has it maybe like once a quarter now, staying low carb. So she never had an appetite issue or major weight issue. She's this tiny little thing, as you mentioned, and, but a very bright, and so, she supported me throughout my own sort of journey in dealing with food and appetite. And, she saw that social scenarios were hard. And so she started making low carb desserts and bringing it with us. And, then it became, wait a second, people with type 1, people with celiac, people who want to, diabetes, who want to, remain low carb and maybe want, instead of flour, almond flour, instead of sugar, monk fruit, maybe they want like easy to make, things. And so, she's a mom entrepreneur. We have 3 kids, and, she was like, okay, well, I can, everything that I've used on you, I was the guinea pig for Rosette's Mixes. So she makes low carb baking mixes, and she, puts it into these bags, and it's her and her sister, Natalie, and they, they own the company, and I have to disclose that on every single research paper I do, which sucks. But, look, the reality is, I think she's providing a service. Do I get a lot of flack for it that my wife owns a food company? I mean, I don't know. Like, what am I supposed to tell her? Don't do what you want to do? Why? Like, she's the lawyer, I don't win arguments. She wins arguments. So, I think it's been a huge passion for her to come up with recipes. And, she's got a sweet tooth. She doesn't have a weight issue. She doesn't have an appetite issue. She has a migraine issue. So she can make these things and eat them. And I think for me and some of my patients, I tell them with these things, just keep it as little as you need, you don't, just you don't use a spare tire just because. You use it when you need it, and that's it, and so when you're dealing with food addiction, you got to be careful with sweet foods and savory foods, and, and I think that's what the adapt bars really are too. It's just like a convenience thing that you can use. And, of course,
we stopped production of the adapt bars.
Oh, you did? Okay. Yeah. All right. Yeah.
Pandemic, because the processing, they were made in South Africa, that you couldn't get flights to deliver product. So we were entirely an educational company now, Adapt Your Life Academy. And
oh my God, got it. Okay. Yes.
We have an upcoming course that's actually open for enrollment right now with Mike and Mary Dan Eads doing a protein course, which, let your folks know or send it around, because the wisdom they have is just unparalleled. I mean,
Protein Power was a great.
Yeah. I mean, and you don't just get protein power. I mean, you get Mike talking about the mummies in Egypt, having atherosclerosis because they made bread, so you get, I'm really excited about this course. That's a protein course at Adapt Your Life Academy. So a couple of questions, and then I'll let you go, or comments. Let's see
well, anyway, just to say, my wife is just, she's been a huge support for me. And so now she makes those mixes. I mean, it's just, it's nothing more than that. If you want easy stuff in your home and you want to, bring it with you to like a holiday or something like that, that's what it's for. The bakers in the world.
The website's literally Rosette's
Mix. .com. Yeah. Thank you for the plug.
No apostrophe, but just Rosette's Mix.
You got it. Perfect.
They're delicious. So the SMHP, Society of Metabolic Health Professionals, is also for people who are not medical professionals. I mean, people can join, coaches and things like that. And
the coaches are medical professionals, so they actually get CPT codes now. Health coaches get CPT codes. So health coaches starting in 2024, this is brand new. They're nationally board certified, and it's crazy, right? I mean, they make everything a CPT code except keto, I guess. Yeah.
So, one last comment and question. Pat is a school nurse in a kindergarten to grade 5 public elementary school in an affluent neighborhood with about 550 students. Several students are who are morbidly obese, although let's say they're heavy, extremely heavy, present to me with various complaints. I want so much to help these children to be healthier, but I'm told by the other nurses that I can't say anything to the parents about it. The thinking is that my concern is obvious and parents don't need to be told. But I wish someone who was writing books on this subject would write one for parents or for children. I wish this could be required education before being parents. Yeah. Well, a lot of things parents need to learn. And the government that provides meals for children, the school need to get on board and correct the upside down food pyramid. I want to make a difference, but don't want to get fired by people who don't understand it. So any thoughts about school age children, or how to make a difference there, Tro?
Yeah, I think, let me tell you what my kids eat. My kids eat, my 9-year-old daughter eats 3 or 4 quarter-pound hamburger patties when she goes to fast food. She eats 3 or 4 eggs in the morning. My son, very similar. My 7-year-old, they have some fruit, they have some nuts, they have tons of, cheese, they drink whole milk. This is what my kids eat. They're all normal weight. They got my genes. I have, the FTO gene, I have the MC4R gene. So they have these genes, and so I think, this is what my kids eat and my pediatrician know. But I think we can certainly lower the, sugar and the glycemic carbs in our kids without blushing an eye. We have a pediatric fatty liver epidemic, and the best thing you can do is call people like me and Eric to go talk to the school.
Yeah,
we'll come out to the school. We'll talk to them. We'll tell them, we'll bring in some family medicine docs like Mark Cucuzella and Laura Buchanan and Matt Calkins. Talk about the appropriateness of lowering carbs in children. I think, the big thing is when you're dealing with kids, you have to think in a way that doesn't, make them feel deprived. So I think things like, something simple, like if they're used to eating chips, getting Quest chips. I mean, if they're, not to say that Quest chips are healthy or that Quest pizza or Blade's pizza is healthy, but kids are used to eating this stuff, and if you deviate them significantly, all of a sudden there could be a lot of deprivation. So I think, when you're dealing with that younger population, just be, considerate to that feeling of being deprived. And, a lot of times you can elicit that shame and guilt. Go back to the story of me in Dr. Adis's office. He didn't mean to cause shame and guilt in me, but he certainly brought that out. And maybe my own vulnerability sort of interplayed there, but so you don't want to elicit that shame and guilt, because that's a trap. You will not win once you hit shame and guilt.
We need to work on a 5-year plan of development for SMHP, Society of Metabolic Health Professionals. One of the things that I always thought would be a great investment would be to hire people to give like a speakers bureau that doctors do, but you don't have to have doctors do it. But, schools get the people to come in and give these auditorium-filled sorts of educational events, and having that be wrapped around sugar as the kind of low-hanging fruit, pun intended, would be a kind of smooth way of bringing in. I think sugar, and too much sugar, is kind of accepted now, I think, right? It would be a safe thing to go into a school and say it should be limited. I hope.
Well, we're doing something right now, actually. Eric and I literally just, bounced back and forth, and we wrote a consensus, not a consensus statement, but we wrote a sort of letter to the editor.
Critical letter. Yeah.
Yeah, critical letter on the AAPs, the American Academy of Pediatrics. guidelines for low carb diets, which, said they recommended in a supervised setting, but more data is needed, but meanwhile, they recommend bariatric surgery and injection drugs. I mean, what long-term data is there in 13-year-olds with that? So, the thing is that I think, the onus is on us. It's not on you. I mean, you can certainly do anything, right? Like you can tell them about the SMHP. You can tell them about Eric and I, but really, like, I think, that lights a fire under my butt to keep doing things like we're doing now, rebel rousing with the American Academy of Pediatrics. Hopefully we'll publish that soon in the Journal of Metabolic Health. We just have to make our voice very clear and spread that voice. Just to let you know, one of my patients did a great thing. He lost a lot of weight with low carb, and, one of his kids had gained weight during the pandemic, and he made like this, just did like a green, yellow, and stop list, right? And the green was, any amount of meat and fish and, cheese sticks and, vegetables and fruit he put in there. And then yellow was like nuts and Quest chips and, protein bars and stuff like that. And red was basically anything else, which was, and he just put this on a big board, and his kid, just following that thing, the kid lost, like a considerable amount of weight. Yeah. Right? So the kids don't need much, You can even put a sign in the lunchroom saying like, hey, if you're interested in getting healthy, ask me about it. So then the kids ask you about it. You're not talking about it, right? You just got a little sign saying, ask your lunch lady about, eating healthy, right? And you may get like 5 kids like, hey, tell me what does this mean, So,
well,
those are my thoughts.
Fantastic. And I'm just, again, I'm inspired by what you're doing. Keep it up. One of the comments here was, and this will be durable material on the web, that doctors and other people need to know the struggle it is to start something like this. Even today, 2023, 20 years after the research really was started, but I think you will come through this and be happy. And of course, our day-to-day life keeps us going because people get better. Anyway, I just want to again say thank you for your leadership. The Low Carb MD podcast has influenced so many people, and it probably laid the groundwork for the Curbsiders, which is a straight internal medicine, interviewing Will Yancey recently, who was my colleague at Duke. So the mainstream podcast now address low carb, and that that's something that never would have happened without the pioneering work that you've done, and I'm glad I was able to provide the foundation so you didn't have to recapitulate all of the studies, right? And even today people are asking me, well, where's the data from your clinic? And I'm like, well, I don't,
the trials.
Anyway.
Yeah.
Thank you so much. Thanks for staying over a few minutes. Please say hi to your family for me, and hope to see you soon at another meeting. And
yeah, it'll be, we should talk about it in January in Boca. We're going to be talking about type 1 and, all topics, but there'll be a type 1 focus. So that's going to be a huge thing. And hopefully we'll have our consensus statement ready by then. So
that's the Society of Metabolic Health Practitioners meeting on the East Coast. We'll be at Boca Raton, usually the end of January, and the focus this year will be on type 1 diabetes, a pre-course or pre-seminar series. That looking forward to that in a big way. So. Thanks again, Dr. Tro. drtro.com is the best place to find you.
Yeah, absolutely. Social media, drtro.com. You can download the app. The app is free. You can just download it. Pretty soon we're going to be giving it to, we have about 10 doctors we're basically giving it away to. And so, and then another 10 slated. So
And the Low
Everybody
Carbohydrate
can go to the App
podcast.
Store and download it. Yeah, and there's so many things. I'm just thinking about it. Too many.
Keep it up while you still have this energy. Go with it.
I'm trying not to burn out.
Take care now. Talk to you soon. Bye-bye.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.